Our patient, who had borderline pulmonary function and multi-station stage 3A disease, has a couple of options for therapy. Because he's not a candidate for resection, he'd be treated with concurrent chemoradiation if feasible. Certainly we have data over decades that show that concurrent therapy is better than sequential therapy. And sequential therapy, by and large, we save for patients in whom toxicity would be a significant issue. So for this gentleman, there are multiple regimens in which we could treat him. Because he has adenocarcinoma histology, reasonable regimens would include everything from weekly carboplatin and paclitaxel to cisplatin and etoposide, or to cisplatin and pemetrexed. There is no one clear winner. These regimens are often defined by what expected toxicities we would imagine. So in a patient with pre-existing neuropathy or renal dysfunction, likely we would do weekly carboplatin and paclitaxel. For a patient who had good renal function, likely we would do cisplatin and etoposide, or cisplatin and pemetrexed. For this gentleman, I chose cisplatin and etoposide, primarily because that is a regimen in which I have significant comfort with. The chemotherapy fits completely during the duration of radiation, and so it's discrete over those 6 weeks. And because the toxicity tends to be minimal, maybe some alopecia and some myelosuppression, but generally it's quite well tolerated. So certainly our treatment of stage 3 disease has evolved over time, as now we've gotten closer to an appropriate radiation dose, where normally patients in the United States are treated between 60 and 66 gray. What has not been as clear in recent years is what the appropriate chemotherapy backbone is for these patients. So certainly a widely adopted standard based on phase 2 data and then replicated in the RTOG trial demonstrated that you could give concurrent carboplatin and paclitaxel with radiation, followed by consolidation carboplatin and paclitaxel, and that led to a very favorable outcome in the RTOG study. However, it's not clear how much that consolidation does, although that's been widely adopted in the United States. Many people, though, because of the difficulty of getting consolidation in after chemoradiation, choose to give cisplatin etoposide. And during that, patients are getting a substantive dose of cisplatin, with giving it day 1 and day 8, and then again for the second part of the radiation. And so generally, my feeling is that patients who have that initial chemotherapy regimen with cisplatin etoposide have completed therapy. We know that consolidation docetaxel leads to inferior outcomes, as demonstrated by the Hoosier Oncology Network. Cisplatin and pemetrexed has been tested in the PROCLAIM trial, and in that regimen, patients got consolidation pemetrexed. Again, we don't have a comparator without pemetrexed, so often we just give the 3 cycles of cisplatin and pemetrexed and call it a day.